So I'm Dawn Ellison from the core group of Healthcare Reinvention Collaborative, as most of you know, I think. And our other core members on the call today are Denise and Jennifer and Wael, who is one of our new core members. Um, Paul is off relaxing somewhere, and Keely, I expect, is working. So that's us. And today we're fortunate to be shining a light on the work of one of our network members. And I'm going to introduce him here in a moment. And just wanted to remind you that our mission is to identify, connect, support, and illuminate every healthcare change maker. We have one guest today. They will describe their work and then they will ask for what they need from the community and offer what they can to the community. Because we only have one guest today, you'll have plenty of time to get to know him and his work, which I'm looking forward to. Once he's finished with his statement, I'll open things up for a conversation, at which time you can ask more about their work, discuss possible collaborations, or just express appreciation for what he's doing. Before I proceed, is there anyone that has any questions? All right, I will go ahead. So, Victor Guajardo is a healthcare innovator who designs medical plans that connect employers directly with healthcare providers, eliminating traditional insurance middlemen and reducing costs while improving access to care. With a background in mathematics and a passion for sustainable healthcare, Victor creates win-win scenarios where employers save money, employees receive barrier-free care, and providers get paid promptly without administrative headaches. His mission is to preserve the healthcare ecosystem by keeping physicians independent and making quality care accessible to everyone. Victor, help us understand what you do.
Yes, so you kind of just stole the thunder. That's exactly what I do. I typically work with self-insured plan sponsors, so groups with 100 or more employees, but I can work with any size. And I remove the middlemen, typically the network carriers. So think Blue Cross, United, Cigna, Aetna. The way I do that is with direct agreements, cash pay model systems, and different forms of providing, whether it be based on a percentage of Medicare or based off of usual and customary for that specific market. It- Additionally, I will work with the stop loss carriers and underwrite the stop loss separately, the medical and pharmacy separately, and direct contract for importation on some of the medications, or get a direct contract between a GPO and an employer. Do my best to bypass PBMs in any way possible. If I am working with a PBM, really locking down the arrangements and the contract between the PBM and the plan sponsor. A PBM is a pharmacy benefits manager. So they're kind of in the news lately. You may have seen them from the Wells Fargo lawsuits. Um, you may have seen them from other type of lawsuits. Congress is auditing PBMs. But what you have to know there is no matter what medical plan you're on, your medical plan does have a separate PBM arm. You just don't see it in the self-funded world. You do see it because you're doing your best to separate the different vendors, so that way you cut out a lot of the games that they can play with earning their revenue. So that's kind of in a nutshell what this looks like.
I'm just
So,
curious if, go ahead, Denise, you go
no,
for it.
please, Don, go for it.
I was just going to say, is there any language that Victor is using that people are going, huh, what was that? Because that's what I do when I listen to Victor. He's so knowledgeable. He's the guy that we would need to be the interpreter with all this healthcare plan lingo. So
Mm.
anybody
Yeah.
else kind of wondering what he's saying there?
Yeah, like all the acronyms, if you would just spell it out, that would be great, what they mean, as you
Yeah,
say them.
absolutely. I apologize. So a TPA is a third party administrator. You can just think of
Ah,
this entity as the entity that's responsible for paying out claims on your group plan's behalf. So let's say you have an employer sponsored health insurance through Blue Cross that's fully insured with your employer. That means that your employer is using Blue Cross as not only a network, but also as the claims administrator and adjudicator to pay all of their claims out according to the Blue Cross contracts. And your employer and yourself are only responsible for paying the premium, but you're not responsible for any of the losses that are incurred. So in that arrangement, it is the insurance carrier taking on full risk for those medical claims. And in the self-insured world, you can separate them and you can rent the Blue Cross network and use a third-party administrator who's independent of the carrier to pay out claims on your behalf according to carrier contracts. Or when you reach different levels, you can use cash-based contracts or you can use reference-based pricing amounts, which are just pricing amounts that are essentially priced against Medicare, plus an additional amount of revenue for the physician's office or provider or hospital system. But at the end of the day, all health plans are built the same. They all have a pharmacy benefits manager, which you may or may not see, a third-party administrator, and a quote-unquote network, depending on the plan design.
Victor,
So
I
what
think
role does the network have? Sorry, Denise, we keep
So,
stepping on each other.
so the network is kind of it's kind of a misnomer. So people view the network as the access to care. A lot of the individuals I speak to, whether they're employees or employers, think that the network, if you don't have Blue Cross or United or Cigna or Aetna, then you're going to have a lot of trouble accessing care. So these network arrangements serve a few different purposes. One, they serve as a blanket, so that way you as an employer can say, "Oh, we offer the Blue Cross network, and you can go to any Blue Cross doctor. And if it's a PPO, then the majority of the doctors are quote unquote in network with Blue Cross. Anytime there's a claim, it just gets repriced according to the Blue Cross preferred provider organization, PPO. I apologize. And so anytime a claim comes in, it's repriced according to the Blue Cross contract, and then it's paid out according to the Blue Cross contracted amount. And so when you receive your EOB, the dollar amount you're paying is actually the dollar amount that Blue Cross says you should pay for that specific service to that specific doctor.
Victor,
And
who's your target
uh-huh.
audience?
It is really physicians, hospital
Ah,
systems. It's anybody who is involved in providing care to individuals. So anybody in the healthcare continuum, really getting them to understand alternative payment models, direct pay, direct contracts between them and the employer, them with cash pay, them with a different type of reference-based pricing. To understand how a group or a plan sponsor can get rid of or remove their revenue cycle altogether. And it's also employers. So it's connecting the two, working with employers to understand, hey, there's a different way than just getting your Blue Cross or your United or your Cigna and letting them run your plan and your costs go up each and every single year. Doing it a different way can help lower your plan costs and improve your population health.
and how would you define, Victor, your company's role in this? Because what it sounds like to me is, and I think Don was saying the other day, you kind of match the employer to the physician or physician group. Is that right?
Yes, to a certain extent. So,
Mm,
my specialty is really pairing the employer with local direct primary care physicians, and setting them up on a risk-based arrangement or a subscription fee. So, typically, I will connect an employer with a local primary care group, and for let's say $80 a month or $90 a month for the entire population, that primary care group will deliver unlimited services to the employee population. And we've really seen that reduce the total claims that
mm,
the group experiences. And so it's really plugging in arrangements that improve population health, which lower the claims experience as a small part of designing these health plans.
mm. I'll be quiet for a moment because I could ask a ton of questions here, but I want other people to have the opportunity.
And I want to make sure, Victor, that you get your opportunity to ask for what you
Mhm.
need and offer
Yes.
what you can to the community if
Yeah.
you're ready to do that. And then we can have more questions later if you wish.
I did see
Yes.
Marlene go off mute though, so I just want to make sure.
Oh, no, I'm fine. Thank you.
Okay, thank you. Okay.
Yeah, so what I need is really for more physicians to, understand and be open to alternative payment models like payment arrangements, direct employer agreements, and their willingness to accept these alternative approaches to getting paid. It's an entire, healthcare community. If we preserve this access to care and we can make it more affordable for everybody. These cash payments are, they pay you same day. So it reduces your reliance on waiting 30 days, 60 days, 90 days from a carrier when you can get it directly from the employer group without any prior authorizations or whatever makes your job harder to perform. And also additionally from the community, really employers being open to breaking away from the traditional brokers who are just going to stick them in the same health plan that has increases every year rather than trying to get to the root cause of the premium increases.
Mm.
Um, what I can offer is expertise in building these sustainable healthcare arrangements, or just providing questions for you to ask to your broker to help them do something different for you. It's not really my intention to become your broker or your consultant or anything, but to help you understand what goes into building a health plan and how you can fight the continual increases and the unsustainability path that we're on.
Mm. So you spoke about what you need being the physicians, and in essence, the physicians being open to the alternative path. When you talk about physicians, it's physician groups, it's more of,
Independent physician groups,
mm,
physicians by themselves, specialists, hospital systems, anybody, if you touch a patient, um, you know, then I want to make you aware of these alternative options.
mm, mm. You also mentioned that you try to stay clear of the PBMs, and I was curious about that. So tell me a little bit about what that means and how you stay clear of them.
Yes, so working with the pharmacy benefit managers, I aim to use them as a specialty purchasing house for these specialty drugs, which are typically biologics or cancer related, which ends up being ran through the health plan anyway. But I have the ability now to purchase drugs similar to the same way Mark Cuban does and
Mm,
get those types of arrangements set up between the employer and the vendor that helps them with that. And so that's one less thing they have to purchase through a PBM. Purchasing of generic drugs takes about 70% of the entire purchasing that happens with a PBM. And by changing that alone, you can probably save about 15% of even the most complex contract, right? Just by going direct and working with an arrangement that can access a group purchasing organization directly, working with the importation from Canada, which goes around PBMs again because it's no longer the PBM's contract that gets utilized. It's now the employer's contract with the pharmacy in a different country, such as Canada, the United Kingdom, New Zealand. And so when you build a health plan that has the pharmacy benefits purchasing arm connected to it using a least cost purchasing methodology. So if you can get the drug directly sourced versus if you can get the drug using a hospital 340B or hospital own use versus importing it versus using the PBM contract with their arrangements, building these health plans to acquire the drug wherever it's the cheapest.
mm,
And so that's how I kind of try to go around PBMs. You have some groups that are so extreme that they will only cover what the Affordable Care Act says they should cover, and that's generics only. And for generic only purchasing, you don't even have to use a PBM. You can get with a mail order delivery system.
mm. You know what I'm fascinated by is there's this level of complexity behind the scenes of healthcare that I don't know about everybody else on the call, but I was unaware of just how complex it is. And the value of somebody such as yourself, Victor, who understands the scope of it. I think that's really helpful in this network of HRC when we're talking about some of these complicated pieces. But then when you're working with those groups, your target audience groups, helping them, I would guess, better understand the structure and helping them to navigate a path that benefits both sides, the patients, three sides, the patients, the employer, and the physician group themselves.
Yes, 100%. So what I do for just at no profit to myself, I'm a patient advocate. So additionally, how I can help, our group is people dealing with excessive medical bills.
Mm.
I have expertise in charity care applications, bill reduction strategies. Typically, I can get, 5-figure bills down by about 90%
Wow.
by
Wow.
utilizing IRS code 501R, or just repricing according to Medicare, and having the person, providing verbiage that the individuals provide to the hospital systems that says, hey, I'm not going to pay you more than 150% or 200% of Medicare. And that alone probably will cut a 5-figure bill down by 90% or more. These
Mm.
these hospital bills, they're all the charge masters all just made up numbers, and that's why hospitals are so willing to go down or give discounts. It's
Mm.
the prices were always that to begin with, and it's just knowing that.
Mm.
Um, let me
So their
stop here.
nonprofit status, they have to give away so much, right? So that's how they do
So
that.
yes, so if nonprofit hospitals have to provide with IRS Section 501R, this is the charity care to
Mhm.
to individuals within the 150th percent to typically the 400% of the federal poverty limit. And so you have people who are earning $150,000 but have 3 or 4 kids or
Mm.
family members that do qualify, that do fall into that
Mm.
501R. So some people think they make too much, but depending on your family size, it could be that you still are falling in that federal poverty level.
Wow. Do you find, Victor, that this process of um, how we pay and all of this that you're dealing with, I mean, you've listed off a number of things. Do you find that it's getting more complicated each year, or how have things shifted as you've stepped into this?
It is and it isn't. It is getting less complicated because you have more level funded carriers. Level funded is just think of a typical fully insured health plan where they change out something called stop loss.
Mhm.
Um, but you have more risk pools essentially getting into the marketplace, offering coverage at no cost because you're able to direct people to low cost, high effective physicians. What stop loss is in all of this arrangement, and any health plan, whether you're fully insured or self-funded, will have stop loss. What stop loss is reinsurance. So it's insurance on top of your insurance inside the healthcare world. So let's say somebody has $1 million claim, you can have a individual stop loss policy for,
Mhm.
let's say, 300,000. So that means you as the insurance carrier or you as a self-funded group will be responsible for no more than $300,000 in medical claims for that one individual person. So you do have several entities who are entering the healthcare arena, like Curative or Level Health or any of these other names that are very popular, offering free care to individuals as long as they stay in network. So using either calling a concierge number or visiting a website. And the reason you have plans being built like that is to control how much the plan is spending. So that cash that I mentioned, if you pay cash, I'll use a pregnancy, for example. A pregnancy at risk cesarean will run you through insurance maybe around 30,000. If you pay cash, you're probably looking at about 13,000. Again, this all
Mm.
depends on the region you're at.
Right.
But that's just to give you an example of how much cash reduces the cost. And so a lot of these captives or these risk pools use exactly what I'm talking about, to lower their cost. And of course, they're incentivizing the plan members. So they're saying, hey, plan member, you have a $5,000 deductible, but if you help us coordinate with your doctor and the facility, then you'll have a zero cost deductible. And the reason they do that is because they're saving so much, right? They can save up to 70% on a typical claim, if as long as they're running things the proper way and changing how they're paying out for things. So in that aspect, there's a lot more of these entities popping up across the marketplace being offered to employers, which is good. Um, some of them you have to, filter and see where they're purchasing their stop loss and kind of what their intentions. Are they just trying to grow super fast to sell off? Are they truly trying to do something different? Who are these people? Who are their stop loss carriers? Who provides their financial backing, kind of thing. So you're starting to see more of that in the marketplace. You are starting to see more vendors and take advantage of the cash pay adjudication as well. You are starting to see more employers being receptive to reference-based pricing or reference-based pricing, like repricing, which repricing is just receiving a claim and then deciding what you're going to pay based on either contracted amounts or market amounts or cash amounts, right? But you're changing the price based off of some metric that's pre-decided when you implement this. So you do have more of the market shifting that way, more employers trying to be self-funded. The issue is a lot of employers are still being, I don't want to paint brokers in a bad way, but they're still, the brokers are still keeping them a certain way with carriers that is creating significant loss ratios against the employer's pocketbook. So you do have a lot of middlemen getting in the way of proper change. And I think the only way to change that is through something called the Consolidated Appropriations Act, the CA, which went into effect in 2021, which is, we're starting to see lawsuits pop up here and there for employers not acting as fiduciaries regarding the employer-sponsored health plan.
It's just fascinating to me. So I'm going to ask an example question, Victor. My husband works for a company out of Canada, and you said you're not US based per se. You're globally connected here. So his company is fairly small. I think there's like 600 employees. Each year their insurance costs have gone up, and so the company has moved to different insurance plans at least 3 times since my husband's been with them for 6 years. And one of the things that the company has identified is there's just a handful of employees who have very costly conditions. My husband happens to be one of them. He has MS, and twice a year he has to get an infusion that each one of those is $150,000. And so that hits their insurance costs. Would you work with a company like that, an organization, and help them to reduce costs through the way that you're helping them to set up a plan?
Yeah, so that's actually my specialty, is those really high risk groups that are running at a 200 or 300% loss ratio, because it is changing, the metrics on the acquisition of drugs, right? Canada's obviously different, right? It's not a US based company, so if it's based in Canada, obviously it has different rules that we would have to abide by there. But if that were a US based company, absolutely.
Okay. I could geek out and talk with you for nonstop, but I'm going to stop here and see if other people have questions or will.
I was curious what the barriers that you're seeing in your business. You've mentioned a lot of education and knowledge. Is it just providers not knowing that these alternative methods are out there, or that it's possible for them, or is it finding the providers, or what, something else?
It is a mix of providers not knowing. So like I'll give you an example with cash, right? You have a lot of providers who are like, oh, you can pay me same day. Yeah, I love this. Or if in certain states or cities with reference-based pricing, depending on the TPA, If you're paying the providers within 2 weeks, they're like, oh, we really love this or whatever it is. Yeah, we'll absolutely take X percentage above Medicare because you're paying us right away and you don't have any of these weird pre-authorization rules. So it's a big mix of providers not being aware that there are other methods of payment. It is also a mix of hospitals not being open to negotiating with anybody who's not Blue Cross, United Cigna, even if you are offering to pay those hospitals same day, just because they are earning so much off of the carriers, which is really a cost that's being passed on to you as the consumer.
Mm.
But
I'd like
ultimately, if you wanted to play hardball, that let's say with like reference-based pricing, or any of those types of metrics, you definitely could. You could inside your health plan, you could build in a team of attorneys or one attorney. And if a hospital tries to come back and say, "Hey, you didn't pay us enough," you can show them proof that's from machine readable files or from other court decisions or from what's usual and customary,
Mm.
and send a letter and say, "We did pay you fairly," and then 95% of the time they say, oh yeah, you did, and then they go away.
Mm.
So there's a lot of different ways to slice it. Just it depends on how much you want to fight.
Mm.
Victor, I'd like to hear a little bit more about your quality of care and your access to care. So how do you ensure that somebody has the ability to get the best doctor, the best care, and the best quality?
Yeah, so that's actually my favorite part in all of this. So I currently use something called GAM metrics, GAM. It was set up by Dr. Will Brunn, who was a student of Dr. Marty Macri. And what GAM measures does is it takes all the CMS public data in addition to insurance data. It does look at clinical outcomes. And it is those physicians who are providing the good clinical outcomes who happen to be low cost as well, who are being listed on any of these health plans as saying, hey, if you visit them, it's no cost to you. So that is one of the ways we're doing it. If it's not that way, it's doing it with care navigators who are nurses. And the nurses are able to use the data as well to drive individuals towards physicians who have those good outcomes.
What
I
if
love
somebody has a rare illness though, and there's very few doctors in the nation maybe, and they want to be able to access that doctor?
Yeah. So we would this actually happened with a spinal surgeon. So it was in Houston. There was one doctor on the carrier side who they were like, yeah, let's go with them. That doctor actually had poor outcomes. The fantastic doctor with great outcomes accepted cash for about a third of the price. And so obviously we got them with that doctor. So in any of these health plans, it's either a cash, hey, can we pay you cash? Or no, you don't accept cash. What other method of payment? Only insurance, fine. We'll run it through there and get a single case agreement. So there's always a way to overcome the barrier to the access of care. We're not going to tell somebody don't go there or anything like that.
I loved, Marlene, that you asked those questions. And then Victor, your face just lit up. That was great.
Those are, I mean, that's really the whole design behind these health plans is to go with the best clinical outcomes because the best clinical outcomes are actually the cheapest.
Mm.
Those physicians are paying less in insurance, and it's on their side, their PNC side, and so that's less cost they have to pass on to you, and that's less of a likelihood somebody's going to get sepsis and end up in the same hospital system, or somebody's going to pass away or anything. So all around, you are achieving those savings by using those highly effective physicians.
Mm.
So I'm curious, Victor, with more physicians, not very many yet, but more physicians becoming direct primary care practitioners, right?
Mm.
How does that interface with someone like yourself, where
So
their model is very different from everybody else's? How does that work?
those, yeah, are subscription based typically, and I would always try to build in their subscription into the total premium for a group. So the group could utilize that primary care physician for their entire population, right? Because that's how we're mitigating chronic illness and improving the health of the population. Or, I mean, what you could do is you could build in a health reimbursement account into any of these groups, and then uh, call it $50 to $80, and individuals can go and use that to pay for their primary care physicians if they want to do it that way. So there's many ways, but I always my default is to always build in a health plan with the idea of having a direct primary care integrated, and if not, at least providing money or making it no cost for individuals to go see their PCP. There I try to get around the wait times and the hold times of visiting a PCP because they're increasingly harder to get, people waiting months, things like that. And you don't see those type of wait times around the subscription model, which is also why I'm in favor of it.
Mhm.
So a lot of times you are working with the direct primary care practices.
Yes.
Excellent. You're finding those growing, I expect. More of
Yes.
them.
So especially here in Texas, we are seeing a lot more growing, and that's just music to my ears because it makes my job a lot easier.
Absolutely. Cool.
Victor, I had another question about the pharmaceuticals. So you mentioned that you could source them from different countries. I thought I
Yes.
understood you said, okay. So how do you ensure the integrity of that medication? You know, you hear so many things about one medication in this
If
country
it's
could be
something
mixed differently and, I don't know.
cold chain and all of that is monitored on the individual drug level. And so a lot of these drugs are actually imported. They're exported out of the United States to another country and then re-imported in order to get those prices. So a lot of it is just setting up the chain for for a drug that originally comes from the US anyway. And so it's just a way of purchasing the same drug that was manufactured here, and following just creating a giant ring to get it back where it was already intended to get, but just taking advantage of the new price that a country like Canada has.
Mm.
So it was always a US drug. We just had to play games with it to get the Canada pricing in some instances.
Process. Victor, do you have, for those of us who understand things best visually, do you have like a visual of like case examples of what you try to show us?
Yes, so I do have several examples of plan designs, which is actually my favorite. I pitch these, I kind of refer to myself as building these billion-dollar jets that don't get used.
Oh.
A lot of the time they are plans designed with no cost sharing because my goal is to remove the barriers to access to care. By removing the barriers to access to care, you're getting the population healthier because people are getting seen and diseases are getting caught that much sooner, which means the plan is going to pay out less and avoid potential ER situations or potential chronic diseases. So being fiscally responsible just happens to align with keeping people healthy. And the ultimate goal is to keep people healthy. And your reward is not spending a lot of money on healthcare, which lowers premiums, and then everybody's happy.
You know, I think that's really interesting. Just the other day, somebody mentioned on a call that there is the challenge with that is many of the healthcare organizations, of course, are making money because people are sick. And so if we make the population healthier and they're not using the services as much, then the healthcare organizations aren't going to be making the money. And so it's this negative reinforcements
So
system, right?
how you get around that actually is, or how I've worked it out with the math is you can have risk-based payments towards some of these organizations. So let's say you're working with a spinal group or orthopedic group, and obviously if they don't have any orthopedic claims, then they don't get paid. You can set things up in such a way that they they get paid on having successful surgeries, and then you can overpay them or things like that. They're different, and by overpayment I don't mean paying them more than the insurance would have normally paid out. But if they're, let's say for example, you're paying 150% of Medicare for meniscus repairs or something, and you're going at risk based arrangement, and the they're guaranteeing like, hey, based off of this, nothing's ever going to happen. nothing ever happens. And so part of that total payment is no longer 150%. You now make it 170%, right? So it keeps them salient. The what you mentioned is really only affects certain hospital systems. And that's more of a community type of arrangement you have to get put in place um, to change those potential negative outcomes by having a population who is healthier, so you need less medical care in the region. But that's not necessarily a bad thing.
Yeah, we could talk about that for quite some time. The other things in that feedback loop of that community that it would benefit, but
Back to the community is
yeah.
you take any of these 501 nonprofit hospitals, right, or community-owned hospitals. By having less medical claims, you're actually reducing the stress and the expenditure on those hospitals, which doesn't affect necessarily the financials, but it does affect the overall stress that and burden that hospital system has to bear, especially for your rural communities.
Mm.
Mm.
You know, I could see you, Victor, connecting with an organization like Nurses Transforming Healthcare, who has this program that they're working to create called Flip the Zip. But in essence, they're saying, is there a different way of providing care within a community that if we're providing more wellness-based care, that we're keeping that community healthier, we are reducing the overall cost and burden on that community. I think that your ability, the way you are able to think of alternative ways, partnering with their thought of this Flip the Zip program might actually help them to figure out how to they just want to pilot in one zip code. How do we pilot this? It might be an interesting, and I'm specifically mentioning that because a member of their board is on this call right now, and she might bring that back to their team.
Yeah, that'd be a great policy. I mean, so think about this one group, Rosen Hotels over in Florida, right? They have an on-site clinic, free care for their members who stay in network, those types of thing, and they did flip the zip. So the original
Mm,
zip code had the community was highly in debt. None of the kids went to college. It suffered from chronic diseases. It suffered from people coming over from different countries who were already extremely ill,
mm,
jumping on the health plan and driving the care up.
mhm,
Over time, the Rosen Group was able to improve the health of those individuals, lower the claims ultimately that the hotel group had to pay out, and start a college fund for the children of the people who work there. And eventually they had 100% of the individual's children who work there in that zip code start attending college. The crime rate decreased significantly, and the overall cost of healthcare reduced significantly. So, I mean, the flip the zip thing is very possible.
mm,
And as you can see, it does have a chain reaction, right? And you see this from zip codes that are literally across the train tracks. The wealthy zip code on the left, the poor zip code on the right, and the wealthy zip code on the left lives 20 more years than the
right,
zip code on the right, all because they had different access to care and
right.
food as medicine, and different social determinants of health, if you will.
Mm.
And so this is a very true undertaking.
Mm. I should also connect you with Sam Kosian, who he and his team are seeking to purchase rural hospitals and really flip their way of doing things. And I think that he would find it very interesting to talk with you about how to do that purchasing side, that financial element.
I would love to work with rural hospitals. I mean, these are the people that actually need something like this. And if they are a rural hospital and if a federally qualified hospital as well, you can even use the hospital's list pricing to purchase drugs for the group, and the hospital can earn a small profit on it as well.
Mhm.
Um, so there's different ways to help that hospital earn profit and keep the costs low for the
Mhm.
groups that partner with them.
Mhm. I've really enjoyed this. Don, I
Yeah,
saw you.
oh no, that's Victor, you're just so knowledgeable in this area. I'm just continue to be amazed at how much you know about this and how little I know about it. So
Mhm.
I appreciate that there's someone that really geeks out on this like you do. Judy, did you have a question?
Yeah, I had a question for Victor. Um, when you're doing this, is it your group is totally separate from the big insurance guys?
Yes, so I do this several ways, through several different partnerships. So one of them is with a supplemental benefits TPA called First Financial Group of America. Another
Mhm.
is independent on my own. Another is with an actuary,
Okay.
and another is with a group of fiduciary benefit advisors who take on fiduciary liability when creating these health plans for employers.
Mhm.
So it just differs, but I'm not associated with any big brokerage houses.
Okay. Thank you.
Oh,
And that also helps because those big broker houses have overhead, right? They have to pay their in-house actuaries, they have to pay their in-house account managers, and everybody who's needing to earn revenue. By doing things this way, I have no overhead costs, right? My overhead cost is this internet connection and my brain. So that's about it.
oh,
So I had linked, when I look at your LinkedIn, it looked like you're with a company. And so I had put that in the link. Is that right? And I'm trying to look you up right now to see.
So the
Yeah.
FBA,
Yeah.
Fiduciary
Yeah.
Benefit Advisors, that is
Yes.
a company that we all work together.
Okay.
So it's we do work together. Sadly, we haven't had very many clients. It's been slow going to try to get the word out about what we do for that specific group. But we are trying as the word fiduciary gets more popular and
Mm.
as people start to understand the potential exposure that they could have by not doing things the right way. Hopefully, it grows.
Mm.
Mhm.
So if,
I do keep my LinkedIn like super separate than right like
mm,
my FFGA work and things like that, just because I try to not paint a target on my back for a lot of this stuff.
so is it best if we were going to put links for how people would learn more about you and what you do, just put your LinkedIn profile?
Yeah,
Okay.
absolutely. My phone number is on there. My
Okay.
licenses are on there. My degrees on there. So very transparent about who I am and what I do,
Okay.
minus the association with First Financial.
Okay.
What's your last name, Victor?
It's Guajardo.
Oh, spell
It's
it.
a G as in golf, J as in Juliet, ARD as in Delta, O as in Oscar.
And I just dropped your LinkedIn profile into the,
Oh, good.
yep.
Thank you.
And
yeah.
Judy, Victor's also a member of HRC, so you can find him on the
Oh,
platform there
okay.
too.
That's what I was going to ask.
Yep.
Which brings up one of the things I want to make sure before we all depart is if there's somebody that you want to connect with, make sure you get on the platform and connect with them. Also, there are a number of events coming in, but before I get into listing those, Victor, thank you so much
Yes.
for bringing us your expertise. And I love understanding more of the why that you do what you do. This was really helpful. And I see Marlene clapping for you. That's great.